Hi, Mrs. Smith. My name's Royanne. I'm going to be your nursing student today. I'm just going to do a few assessments on you first. Is that all right?
Sure.
Can you tell me your full name and your date of birth, please?
Cindy Smith, December 2nd, 65.
Perfect. I'm just going to check your wristband. Great. Everything looks good. Next, we're going to be doing a quick scanning of our patient before we move on to the genitourinary system. We can start by doing a quick neurological assessment by checking the alertness and the orientation of our patient. So, Mrs. Smith, where were you born?
Toronto.
Do you know what year it is?
2020.
And where are you now, and do you know why you're here?
I'm at Toronto Western, and I had some problems breathing with my COPD.
When we're talking to our patients, we also want to pay attention to our patient's speech and note if the patient's speech is fluent, as well as the pace, volume, and clarity. My patient appears to be alert and oriented, and she can follow my commands and is very talkative. We also want to quickly look at the facial expressions to make sure everything looks balanced. Mrs. Smith, can you give me a big smile and show me your teeth? Perfect. And can you open and close your eyes for me? Great. Next, we want to do a scan of the respiratory system, and we're going to do a quick lung auscultation. Using my stethoscope, I want to listen to a full breath at each of the landmarks of the posterior chest and work my way down the patient in a predetermined pattern. We want to compare one side of the chest to the other, and we also want to observe the presence of a cough or any shortness of breath. With my COPD patient, we would expect to hear some wheezing. Moving on to the cardiovascular system, I begin by palpating the radial pulse of our patient to assess their heart rate. The normal BPM is 60 to 100 beats per minute. Moving on to the cardiovascular system, we're going to begin by palpating the radial pulse of our patient to assess their heart rate. The normal BPM is 60 to 100 beats per minute. And in my COPD patient, we can hear that the heart rate is strong and regular, and her heart rate is 105 beats per minute. We'll also perform a quick auscultation of the heart, listening with the diaphragm of our stethoscope first, and then we're going to move on to listening with our bell afterwards. We're going to start at the aortic landmark and then work our way down. Once we have completed an auscultation of the heart using the diaphragm of our stethoscope, we'll repeat this process using the bell. In our COPD patient, the heart rate sounds normal, and the heart rate is a bit fast. Before moving on to the abdomen, we want to check for peripheral edema. Patients with COPD may have swelling in their ankles, legs, and feet due to complications of COPD called pulmonary hypertension and cor pulmonale. Okay, Mrs. Smith, so when was your last bowel movement?
I think yesterday.
Okay, and what is your regular bowel pattern? Do you have a bowel movement every day?
Usually every other day.
Okay, is there anything that you're taking to help you?
Metamucil. Usually I take Metamucil once to twice a day.
Okay. Do you have any difficulty voiding, or have you noticed any changes at all?
No, everything's the same.
Perfect. Next, we want to perform an auscultation and palpation of the abdomen. We want to listen for bowel sounds using the diaphragm of our stethoscope. Following the auscultation, we can perform an abdomen palpation. We want to start by shallowly palpating the abdomen and continue by systematically palpating deeper into the abdomen to assess the internal organs. We want to make sure that we're taking note of any pressure pain, rebound tenderness, or abdomen masses. Next, we'll do a quick scan of the musculoskeletal system. Start by asking our patient to stand up straight and quickly walk in front of us so that we can assess their gait. We also may want to palpate and assess the strength and range of motion of the upper and lower body of our patient. Next, we'll move on to the genitourinary system. We want to start by obtaining a brief health history background and see if the patient has any complaints. Okay, Mrs. Smith, have you noticed any changes in your voiding at all?
Not really. I don't think so.
Okay, so have you noticed any pattern changes, such as hesitancy or the frequency of urination? Any trouble with incontinence or color changes in your urine?
No, I think that that's all normal.
Okay, and no pain at all while urinating?
No.
Okay, perfect. Do you have any past illnesses or pre-existing conditions related to the urinary tract?
No.
Okay. How about any medications? Are you taking any medications right now?
I take my puffers for my COPD.
Okay.
And that's all.
Okay. And how about for your family history? Do you have any history of kidney failure or kidney disease?
No.
Okay. Okay, for the reproductive system, we want to obtain the most complete data about these problems, and we can focus our questions on the patient's current complaints and then explore her reproductive, sexual, social, and family history. So many patients will feel uncomfortable answering questions about their sexual health or reproductive system. So we want to start with less personal questions to help establish rapport. We can ask questions about her menstrual cycle, sexual practices, pregnancy and fertility, or menopausal questions. We want to start by observing the area around the kidneys and bladder and see if there's any abnormal color and shape. Following inspection, we can palpate around the kidney area and percuss both sides. Because the kidneys lie behind other organs and are protected by muscle, they normally aren't palpable unless they're enlarged. Next, we'll move on to the bladder. To percuss the bladder, we'll first make sure our patient empties it, and then we'll ask her to lie on her back. We'll start at the symphysis pubis and percuss upward toward the bladder and over it.